Hey guys, so today I'm going to be talking about abnormal placenta cord insertions. Our first one up is called the battledore placenta. So in this case, the insertion of the umbilical cord is at or too close to the placental margin. So as you can see here, we have our placenta, our cord with a color flow on top, which is displaying that the cord insertion is at the edge of the placenta, which is no bueno. If it pulls away, nutrients can't get into the cord. Our next one is called the filamentous insertion. So the umbilical cord inserts into the fetal membranes and then travels to the placenta within the membranes. So it is not attached to the placenta, as you can see here. The cord is going up and straight into the membranes. Our next one is vasa previa. So this is when the membrane carrying vasa previa is membrane carrying vessels that are positioned across the internal cervical os. And that's exactly what you see in this picture right here. We have color flow on, which is very important to always put color flow near this area just to rule out this sort of abnormality. You see the cord, which is again highlighted with color flow, running right across the cervical os, which is right here. Okay, so there's also another type of placental abnormality, which is basically a placental abruption. There's two types. The first type is retroperitoneal abruption, which is what you see here. Basically, the uterus and placenta begin to separate before the due date. So right here you have the blood clot forming between the uterus lining right here and the placenta up here. So that is... So another type of placental abruption is called marginal abruption. So with this one, I wasn't able to find a good ultrasound image online, so this one will have to do. But basically it is when the uterus and placenta are still separating, but it's not, the blood clot isn't concealed like with the retroperitoneal abruption. So this one basically just has a clear pathway out of the uterus, and that's why a lot of mothers experience a lot of bleeding. So risk factors with both of these type of abruptions are maternal hypertension, short short umbilical cord, uterine anomaly, myoma, trauma, and placenta previa. So the next topic that I'm going to be discussing is chromosomal abnormalities. The first one we're going to talk about is trisomy 13, aka Patau syndrome. So this happens in 1 in every 6,500 births, as it deals with an extra chromosome, which is number 13. So with this syndrome, many anomalies involve the brain, and we're just going to be talking about the most common types. And the first one is holioprocephaly, which is basically an abnormality of the brain development in which the brain doesn't divide into the left and right hemispheres. There's 3 forms of this type of abnormality, which is alobar, semilobar, and lobar. But we're just going to be talking about alobar, and that is exactly what you see in this image here. The thalamus basically is fused together. Again, they're supposed to be left and right. This is the most severe type, and the prognosis is poor. So the next physical feature of trisomy 13 is hypotelorism, which is just the abnormal decrease in the distance between the two eyes. As you can see here on ultrasound, that is exactly what is shown in this image here. Here is another image as well, just how we would measure the abnormality and putting calipers on each eye socket as well as the distance between each eye socket. Another physical feature is proboscis and cyclopia. They usually go hand in hand, but proboscis is elongated facial appendix, and cyclopia is just having one eye. As you can see here, we have the ultrasound image and then the physical view next to it. So these are definitely some key things that are apparent with trisomy 13. And just to give you a better idea of what cyclops looks like under ultrasound, this is a really good ultrasound image. Our next physical feature is omphalocele. and it is an abdominal wall defect in which abdominal organs are atypically located within the umbilical cord. Basically, it's just when the bowel does not return to the abdomen. It is encapsulated by amniotic and peritoneum. Sonographically, you would see a bulge near the abdominal region. And the last most common physical feature is renal abnormalities. This one is very echogenic. The prognosis for this syndrome is very poor. 80% of infants die within the first month. Sonographic features are evident in 90% of fetuses, so this is a syndrome that can be caught. Some extra information to remember about trisomy 13 is that 90% of these infants have cardiac defects. The mom will also have a decrease in AFP. As far as the physical features go, there are 3 that you should really know. If you take anything away from this video, please remember these 3. The first one is holioprocephaly, which again is when the right and left hemispheres fuse together. The second one is polydactyly, which is basically when you have an extra finger or toe, because it can happen to the feet or the hands. The third one is microcephaly. I put in a little cartoon image because I thought this would be explained better this way. The first one to the left is a normal head size. The middle one is microcephaly. And then the third one is severe microcephaly. So basically the head size is just smaller, aka micro. It's a good way to remember it. So those are the 3 that are most apparent. Let me go ahead and show you an ultrasound image as well. And here it is. So basically the head circumference is just very much smaller than what the dates predict. Our next topic is trisomy 18, which is also called Edwards syndrome. It basically is an extra chromosome, which is number 18. This syndrome occurs in 1 in every 8,000 live births. The physical features to keep in mind have to do with the corpus callosum. This ultrasound image here has a normal corpus callosum. But when it comes to trisomy 18, one of the physical features has to do with the agenesis of the corpus callosum, which basically means it's not there. So as you can see, you don't see that anechoic structure in the middle. Our next one should sound familiar, which is microcephaly. It was apparent in trisomy 13 and it also is in trisomy 18. So basically the head circumference is smaller than normal. Our next one is hydrocephalus, which is an abnormal accumulation of CSF in the ventricles. The next ultrasound image I have pulled up here is called encephalocele. It basically is a sac-like protrusion or projection of the brain and the membranes that cover it through an opening in the skull. So it is kind of similar if you want to reference back to omphalocele, except of course that is involving the abdominal bowel, whereas this is basically the brain. As far as the extremities go, the most common physical feature is persistently clenched hands, and that's basically found in 80% of infants that have trisomy 18. So they're always just clenching their hands. So overall, trisomy 18 does have a pretty poor prognosis. 90% of infants do die within the first year, but the sonographic features are evident in 80% of affected fetuses, so it's very important to keep an eye out for these physical features. So some information to remember with trisomy 18 is that 80% of cases display clenched fist, and the mom will have a decrease in AFP. So all of the physical features that I mentioned previously with trisomy 18 are all very important, but the next 3 that I want to highlight are some that are more common than the ones that I already explained. So the first one out of the 3 is cord plexus cysts. So self-explanatory, there are cysts in the cord plexus. As you can see here, this is an ultrasound image of how we would measure it in SAG. Very apparent with this syndrome. The second one that we already went over, again, clenched hands. Again, it's 80% of cases mostly have this physical feature. So the last one of the three is having a 2-vessel cord. As we all know, normally we are supposed to have a 3-vessel cord, so 2 arteries and 1 vein. So our next topic is going to be trisomy 21, which is Down syndrome. This happens in every 14 births out of 10,000. It does have to do with an extra chromosome, which is 21. It is associated with a high nuchal translucency test, abnormal first try screen, and an abnormal quad screen. The first physical feature that goes with trisomy 21 that I'm going to go over is called brachycephaly. And that is basically when the back of the skull is very flat. As you can see in these images, this is a normal skull, and then the rest, the other two, show you how the backside is just completely flat. Some other physical features that tag along with brachycephaly is having a flattened nasal bridge, round or small ears, and then a protruding tongue. This next physical feature is very apparent with Down syndrome. If any infant has this, they most likely have Down syndrome. It's basically a complete blockage at the phyloric sphincter. We as sonographers call it the double bubble sign, which means 2 echo-free communicating structures, which is the stomach and the duodenum, in upper fetal abdomen. Hydramnios is almost always seen with this physical feature. Here's another image of the double bubble sign. Another feature that we always like to measure that is a good indication of Down syndrome is the nuchal fold. If it is more than 5 millimeters, that is a red flag. So this is basically what we're measuring. It's the fluid behind the neck. As you can see here with this ultrasound image, this is definitely more than 5 millimeters. The last characteristic that I'm going to be mentioning concerning Down syndrome is having a small or absent nasal bone. Like the image that I put here, you can already tell that this is smaller than usual. Some information to keep in mind when talking about Down syndrome is that it is the most common syndrome out of all of them. You will have a decrease in AFP, but you will also have an increase in HCG. So our next topic is called triploidy, and it is a result of a complete extra set of chromosomes. It often occurs as a result of an ovary being fertilized by 2 sperm. It happens in 1 in every 10,000 births, but most infants will spontaneously abort. There are a couple physical features with this syndrome, but a lot of them revolve around heart defects and renal abnormalities. The first one that I do want to talk about is meningomyocele. It is under the spina bifida physical feature, which is another abnormality, but basically it is a neural tube defect of the spine in which the dorsal vertebrae fail to fuse together, allowing the protrusion of meninges and or spinal cord through the defect. So with this type of abnormality, meninges and neural elements protrude through the defect, which is one of the most common types out of them all. Some of the other characteristics that we have already discussed in previous syndromes that are also apparent in triploidy are omphalocele, holioprocephaly, and agenesis of the corpus callosum. So the next abnormality is the Dandy-Walker malformation, and that is the underdevelopment of the cerebellar vermis, cystic enlargement of the fourth ventricle, and the enlargement of the posterior fossa. So to the left, everything looks normal, and the right one does have the Dandy-Walker malformation. You can see the posterior fossa cyst as well. And this is how the posterior fossa cyst would appear on ultrasound, so that would definitely be an indicator of the Dandy-Walker malformation. The last characteristic that I want to discuss concerning triploidy is called cryptorchidism, and that is basically a condition in which one or both of the testes fail to descend from the abdomen into the scrotum. So just to wrap up triploidy, just remember it is 3 complete sets of chromosomes, and most will spontaneously abort. Our next topic is Turner syndrome. This is a genetic abnormality marked by the absence of the X or Y chromosome. This happens in every 1 in 2,500 live births. It is not associated with advanced maternal age. So Turner syndrome may present with elevated MSAFP, which means maternal serum alpha fetoprotein, when cystic hygromas are present. So what's a cystic hygroma? It's a fluid-filled structure that surrounds the neck and extends up to the head or lateral to the body. It will have a dilation of jugular lymph sacs because of improper drainage of the lymphatic system. And this is an ultrasound image of it. As you can see, the cystic structure is more on the superior end. So some physical features to keep an eye out for when it comes to Turner syndrome is the coarctation of the aorta, which just means that part of the aorta is narrower than usual. And that's what this ultrasound image is pointing out here with the arrows. You can see it does taper down towards the middle and then goes back to its normal size. And this is an example of how we would measure it all the way down. The others include general lymphedema, high drops, renal abnormalities, especially it can be horseshoe kidney like the image that I'm showing here, which just means that there's a connecting isthmus between the right and left kidney. There can also be renal agenesis, which means there's no kidney, hydrophenosis, which is fluid within the kidney, and then the last one would be a hypoplastic kidney, which means that they are smaller than normal. So the prognosis with this syndrome is grave, especially with fetuses that present with large cystic hygromas. But if they do survive, the physical features that they'll be born with and develop later on is just immature sexual development, amenorrhea, which means absence of menstruation, short stature, webbed neck, poor hearing, and an abnormal elbow angle. Some of the sonographic features with Turner syndrome is oligohydramnios, which means that there is little to no amniotic fluid, which will lead to intrauterine growth restrictions. The baby is now confined since there is little to no amniotic fluid. They're not able to move around, stretch out, so they're just confined to that one space. An example of oligohydramnios is this ultrasound image here. As you can see, there's no amniotic fluid surrounding the baby. Some other ones are increased nuchal translucency, fetal tachycardia, and of course the two that we already went over, cystic hygromas and renal abnormalities. Just to wrap up Turner syndrome, 2 things to keep in mind are that it is 45 chromosomes, including 1 single X, and you will have an elevated AFP. So I just want to touch basis on the difference between omphalocele and gastroschisis. And with omphalocele, it is covered by a thin membrane, but it is important to remember that it can rupture, but it'll just be like an outpouching on ultrasound that you'll see the bowel within, but there will be that thin lining surrounding. With gastroschisis, you will have no membrane covering the intestines. So this is an ultrasound image of gastroschisis. It basically means the opening layer of the abdominal walls with invisceration or hernia of the bowel. The cause is atrophy of the right umbilical vein or disruption of the omphalomesenteric artery. So women would have high levels of AFP because of the exposed bowel. Sonographically, we'll see multiple loops of bowel outside the abdominal cavity in the area of the cord. Ascites shouldn't be present, but if the herniated bowel is dilated with wall thickening, it suggests infarction or bowel atresia. So I know we already went over omphalocele in one of our previous videos, but just to reiterate, it is only a abnormal wall defect when it surpasses 12 weeks. So between the 8 and 12 week mark, it is considered normal because basically the fetal bowel normally migrates into the umbilical cord from the abdominal cavity because it lacks space in the cavity because of the liver and kidneys. So the bowel is then forced from the abdomen, which allows the bowel to rotate around the SMA. But then it should return into the abdominal cavity by the 12th week. And when it doesn't, that's when it's deemed a defect. So there are two types, those that contain the liver within the sac, and then those that contain a variable amount of bowel without the liver. So next up, we're going to be talking about infantile polycystic kidney disease versus adult dominant polycystic kidney disease. So infantile polycystic is also called ARPKD, meaning autosomal recessive polycystic kidney disease. So the definition is basically it is a congenital disorder that affects both fetal kidneys and liver. You will see small cysts within the kidney and liver. As far as the kidney cysts go, they are caused by tubular malformation and ectasia, which basically means dilation of the collecting ducts, and usually it is the distal collecting ducts. So with ARPKD, it does result in cystic dilation of the renal tubules arranged in a symmetric pattern. As you can see in these ultrasound images, the kidneys are just really enlarged, so that's what it leads to. So for sure we're able to spot this as soon as we put our probe down because this looks abnormal right off the bat. The formation of these cysts on the kidneys are very crucial to recognize because they do lead to damage and tubular dysfunction and possible fibrosis. So here is another ultrasound example of ARPKD. Renal failure will occur due to the replacement of normal tissue by the enlarged non-functioning collecting tubules. Unfortunately, the prognosis for this disease is very poor. It is most likely diagnosed already in utero, and the fetus will either be stillborn or death will occur early in the neonatal period due to the renal failure and the lung hypoplasia. Sonographically, we should be seeing collecting tubules dilated, individual cysts. The kidneys are going to be massively enlarged. The abdominal circumference is going to be thrown off, so it's not going to match the gestational age. We're going to see increased renal echogenicity and possibly oligohydramnios, and lastly, a small or absent bladder. So now let's move on to adult dominant polycystic kidney disease, ADPKD for short. It is defined by a cystic dilation of nephrons and collecting tubule walls. So the cause of ADPKD is a defective gene that does not allow for normal epithelial cells to develop. It results in a cystic development of the cortex and medulla. The thing about this disease is that these cysts do not enlarge or impair kidney function until adulthood. And one thing to keep in mind is that this is the most common hereditary renal cystic disease. And although it does manifest in adulthood, it can be diagnosed in the fetus when there is a family history of polycystic kidneys or liver, or even both of them. Usually when there is a visualization of bilateral enlargement of the kidneys, it does prompt a liver and kidney workup in the parents. Some of the associated anomalies are liver, spleen, or pancreatic cysts, cardiac malfunctions, pyloric stenosis, and skeletal abnormalities. The prognosis is really just dependent on the development of the cyst formation, and sonographically we are going to immediately see the cysts kind of consuming the whole kidney. Our last topic is going to be prune belly syndrome, and it is defined by 3 features. The first one is cryptorchidism. The second one is agenesis or hypoplasia of abdominal wall muscle, and then the third one is the dilation of the collecting system. The cause of this syndrome is embryonic defect of the mesoderm or a urethral obstruction malformation complex. It can also be called Eagle-Barrett syndrome. Some of the sonographic features include the fact that the bladder is going to be anechoic, large, and thin-walled. The prostatic urethra is enlarged, bilateral hydrophreноsis with possible dysplasia. Ureters will be dilated or tortuous. The ureters may appear as multiple cystic lesions in distended abdominal cavity. The last two will be oligohydramnios and a large abdominal circumference. And this concludes my part of the project. I hope you guys enjoyed my videos. I'm probably cringing at my voice right now while you guys are watching this, but I hope you learned something, and my videos will be available on TikTok. If you want to replay them, I will go ahead and send out a link to my TikTok page. Thanks!